How's it guys, and welcome back to my channel. Today we're going to continue with ECGs. If you haven't watched my previous channel, I'd recommend you go check it out, because if you're not quite sure with what's going on this page as it is, you know, PQRST and all that sort of thing, it'd probably be best that you jump back there quickly. But if you have watched that, let's get going. So the best way for me to teach you ECGs is to show you how to analyze an ECG. And once you know how to analyze and read it, you'll be able to work out what it is. Alright, so questions you want to ask yourself is, does this look normal? So first of all, let's look at the rate. Alright, remember, if we count every large block in between the R and the R wave, we are able to work out the rate. So we go, that's 1, 2, 3. So remember, it's 300 divided by the number of big blocks, so that's 3, which obviously equals 100. So that is a fast rate. So now we know that it's relatively fast. So now that we have worked out the rate, let's see whether it's regular. Remember, to work out if it's regular, we take a piece of paper, we mark the Q waves, the R waves, and you see whether those touch. They do touch. Do these touch? Yes, they do touch. And if we continue, you'd see that it is regular. It's important to do that. So it's regular, and the rate is 100 beats per minute. Right, now we want to look at, is there a P wave before every QRS? So there's a P wave, QRS, P wave, QRS, P wave, QRS. All right, and we can't see further out. Is there a P wave before every QRS? So we have correlation between P waves and QRS, because P waves are the atria contracting and the QRS is the ventricles contracting. We do. Now that we know that everything is following everything else, we can look at what is the length, or how long does each thing take. So we're trying to find, is there something abnormal that we can find? So the P wave, or the PQ interval, which is something that we want to look at, is beginning of the P to the beginning of the Q. And that must be less than 0.24. So remember that one block is 0.04, so that's 0.04, 0.08, comes up to about probably 0.12, which is normal for a P wave. Then for a Q wave, it mustn't be longer than 0.12. So that is no bigger than 3 small blocks. So we go, the Q wave starts here, so that's 1, 2, and it ends there. So that's only 2 blocks, meaning it's only 0.08, so less than 0.12. So the QRS is normal, the P wave is normal, the T wave doesn't look any bigger. In terms of T waves, what you want to actually have a look at is if it is bigger than 1/3 the R wave. So if you've got a really small R wave and you've got a really small T wave, that's normal. But if you have a normal looking size R wave and you have a T wave that is half or bigger than that wave, then you know that that is a large T wave. We have assessed this ECG. We can see that the only thing wrong with it is that it is a bit fast. So that can be called a tachycardia, so a fast heart rate. Let's move on to the next ECG. What is the rate? All right, so we're going to count 1, 2, 3, 4, 5, 6, 7. It's at least 7. So 300 divided by 7. That's right. So now that we can see that it is very slow, we can see whether it is regular. Take a piece of paper, put 2 lines. Yeah, regular, and then you continue. From what we can see, it's regular. Do we have a P wave following every QRS? P, QRS, QRS following every P. P wave following every QRS, QRS, P, P, and Q. So they are synced. The atria and the ventricles are synced. All right, fantastic. Now we look at the length. So the P wave can't be more than 0.22 seconds. So that's less than 0.22. Then the QRS is less than 0.12. So that's 1 block, that's 2 block. Yeah, so that's less. So the P wave is the right length. The QRS is not broad. The P wave looks round and normal, and the T wave looks normal as well. So all we can find wrong in this ECG is that it is slow. So this would be called a bradycardia. Let's go to the next. All right. So this might look familiar. So as you can see, there's no P waves, there's no QRSs, there's no rhythm, there's no rate, there's nothing. But what you will notice is that the line is not perfectly flat. An ECG is never perfectly flat. Not that my line's perfectly flat, but you get what I'm saying. That when you have an ECG on a patient and you have a what we call a flat line, it's called asystole. And what that means is that there is no conduction in the heart. But you'll notice that it's never a perfectly flat line. So there's no QRS, there's no P waves, there's obviously nothing happening in this heart. It's a dead heart. All right. So this is one that you might also see and is something that you need to be able to recognize. So we're going to try and find P waves or QRSs or rates, and all we can see is confusion. There's random up and downs, there's no pattern, there's no form, there's no rhythm, there's nothing regular. So what this heart or what this ECG is called is ventricular fibrillation, or VF. What that means is that every cell in the heart is contracting by itself. So each cell in the body is able to contract independently. Here is a dysrhythmia. And what's happening is that all the cells are contracting whenever they want to contract. And so that means that there is no ability for the heart to pump blood in a direction. So you see random ups and random downs and random ups and random downs. And there's no pattern or form to it. This is a ventricular fibrillation because the ventricles, they're very big waves and it's fibrillating. So it's all shaking, it's all contracting independently, and therefore it's not creating a pulsatile flow. This patient will not have a pulse, and this patient will need to be defibrillated. That's about that. This is one of the two shockable rhythms in cardiac arrest. All right, this is another rhythm you will come across. So let's see, do we have a rate? We do. So here is a R wave. There's another R wave, so that's one block, maybe 1.5 blocks. So 300 divided by 1 or 1.5. So let's divide it by 1.5, which means we're going to have 150. All right, so that's very fast. Is it regular? So we see a whole bunch of R waves, boom, 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 R waves, R waves. See, regular, cool, that's good. So now it will be difficult to see what wave is what. All right, so what we're seeing is a very broad QRS. All right, the QRS is starting here and it's ending here. Remember, a QRS can't be more than 3 little blocks. This is 1, 2, 3, 4, 4.5 blocks. So we have a broad QRS. So the rhythm is most likely coming from the ventricles because of how broad it is. All right. So do we have P waves before QRS? I don't see any P waves. So then, well, you might ask, well, what are we looking at? All right. This big wave here is a T wave. Remember, to find the isoelectrical line or the flat line of the heart, you need to look between the T and P, or if there's no T or P, between where you can see something that is flat. So you can see here, there is flat over here. That's always good. If you can write down on the ECG where your flat line is, you are able to see what is what. You'll notice that the P wave is non-existent, which means that the atria aren't contracting, because we know that the P wave is a sign that the atria is contracting and the QRS is the ventricles contracting. We see no P wave, meaning there's no atria contraction. There's only one big broad wave and it's fast. So this rhythm is coming from the ventricles because the heart is able to contract from the ventricle. There's no P wave, so there's no movement of the atria. It's broad and it's fast. Remember, the rate is 150. So we have a fast rate, and it's coming from the ventricle. So what we have is a ventricular tachycardia. This is a shockable rhythm if the patient has got no pulse. So sometimes this can cause a pulse, sometimes it doesn't cause a pulse. It depends on the situation. If the patient has a pulse, you can cardiovert this, but that's a whole nother story. Generally speaking, in cardiac arrest where there is no pulse, you will shock ventricular tachycardia or you will shock ventricular fibrillation. Those are the two rhythms you shock in cardiac arrest. All right, so now we move on to the ST elevation. A lot of people aren't sure how to see it or how to work it out or to find it. We're just going to look at one PQRST and we're going to try and work out where our ST elevation is. All right, so we have a P wave here. We have a R wave here. We have a T wave here. S. And your Q isn't really visible because remember Q isn't normally there. So what you want to work out, so we obviously can't look at rhythm or rate or, is it regular, all those sort of things. But we have a P wave before the QRS and we have a QRS after every P. You want to try find your isoelectrical line or the flat line, remember, which is between your T wave and your P wave. So it would be this line. All right, so now we know where flat is. All right, so what you want to be looking for is your J point. The J point is where the direction changes coming off your S wave. So you have your R, and then it comes down to your S, and then it starts going back up. And the moment it starts going back up, and then it changes direction, which is right over there. See, it goes up straight and then change direction. That is called a J point. That is where we look for ST elevation, because when we're looking at ST elevation, we're looking at the ST segment. So the ST segment is from here to here. Remember? So you got your S and your T, so your ST segment. It doesn't mean what's going on here, it's just at the J point. So you want to count how many tiny little blocks, how many millimeters of elevation we have. So that's 1 block, 2 block, 3 blocks. So we have 3 millimeters of ST elevation. All right. So STEMI is ST elevation myocardial infarction. So this would be classified as 3 millimeters of ST elevation. We will jump into a 12 lead. We will talk about what that looks like, how to see what is what leads are looking at what part of the heart, and how would you see whether there is a ST elevation or maybe even ST depression. Okay, so let's look at a 12 lead ECG. So the first time you look at a 12 lead ECG, you're going to feel rather overwhelmed because there's just so much going on. But all you really need to know is that all of the 12 different views, because there's 12 leads, there's 12 views of the heart. All you need to know is that each view is from a different angle, and that some views look at the same angle. So it is important to know that you have to find 2 leads that are looking at the same place, that are saying the same thing. All right. So how do I tell which leads are looking at what? Well, there is a really cool mnemonic, which is IC or leads. So what that means is the I stands for inferior, the S stands for septal, the A stands for anterior, and the L stands for lateral. So you'll see here that the lead 2 and 3 in AVF are inferior, lead V1 and V2 are septal, V3 and V4 are anterior, and V5 and 6 or V5 and 6 are lateral. And this can also include lead 1, so that's also lateral. That is how you tell what leads are looking at what. In previous sections, we have looked at how do you see ST elevation, and it's exactly the same on this. So we have looked at a bunch of ECGs, and we've always been looking at lead 2. So then this is your classical lead 2. At the bottom, you can see that they have a long line of lead 2, so you can assess it just as we have assessed the previous ones. So you can work out your rate. See, there's 1, 2, 3, 4. There's 4 big blocks in between, so 300 divided by 4, 75. Cool. Normal. Do we have P waves before every QRS and QRS after every P? I can see that we do. It all looks normal. The rate looks normal. The distance of your P and your Q interval is normal. Your QRS interval is normal. Your T wave looks much smaller than 1/3 of your R wave. And then you can look for any ST elevation or any ST depression. And from what I can see is there's nothing. So some waves are positive, some waves are negative. So you'll see that there's a negative P wave or a negative T wave. In some leads that's normal, in some leads that's not normal. So that's just something you're going to have to learn. And you can see that it's all looking very normal. I hope that was helpful. Yeah, stay tuned for more. And if you really enjoyed this, then please hit like and subscribe. It really helps me. Thanks for watching.